Good evening, everyone, and welcome to Momcology's webinar series, Caregiver Lounge. We're so happy you could join us tonight. I'm Kim Buff, the founder and executive director of Momcology, and producing our webinar tonight is Layla Zengel. We're very excited to be doing something a little bit different with this episode of Caregiver Lounge tonight. We are really grateful to be sharing back some recent research that we've done on acute lymphoblastic leukemia. I myself am an ALL parent, and it has been a priority for Momcology to make sure when we engage in research projects that the community has the opportunity to learn from the results. We believe in truly putting the patient and family in the forefront and nucleus of the work being done, and we believe that this time together is an important step in the process that shouldn't be overlooked. We hope to begin to shift that impact of true community-based studies starting tonight. And we are grateful that the research team behind this particular project has been extremely supportive of making sure that this happens. But before we get started and I introduce our speaker tonight, we do have a few housekeeping notes to go through. This webinar is in view-only mode, so we can't see or hear you. You can only see and hear us, so please get as comfortable as you'd like. It's the Caregiver Lounge. We may break for questions during the presentation, so please do use the dedicated Q&A box at the bottom of your screen. And with that, I would like to warmly welcome Dr. Kelly Parker as our presenter tonight. Dr. Parker is a pediatric oncologist at Primary Children's Hospital in Utah. Her research interests include improved care for childhood cancer survivors and their families, and decision-making for enrollment in clinical trials. It has been an absolute pleasure working closely with Kelly and our study team on this project. So welcome to our couch, Dr. Parker. We can't wait to see what you have to share with us. Thank you.
So I am going to be talking about our study that I have been lucky enough to work very closely with Kim on. It's called the Priority Setting Partnership for Pediatric Acute Lymphoblastic Leukemia, and we're going to be talking about some of our study results, and I am presenting on behalf of our bigger team that I will tell you a little bit about. So first I'm going to tell you who's been working on this, kind of what we are doing and why we're doing it. Then I'm going to go over the results, talk a little bit about how we're using these results and what our next steps are, and then we'll have hopefully some good time if people have any questions that we can talk through answers and take any comments or suggestions. All of this is unpublished at this point. We've presented at conferences and we are submitting manuscripts currently, but just a reminder, please to not share outside of Momcology community and your families. All right, so I think an important part of the work that we're doing is really our team and talking about how we came together and why we're doing the work that we're doing. And so I'm just going to take a few minutes to talk through this. Like Kim mentioned, I am a pediatric oncologist and I specialize in leukemia and lymphoma and survivorship, and have an interest in both decreasing toxicity and burden for patients and families and in clinical trial decision making. And because of these interests, I ended up getting involved with the Children's Oncology Group ALL committee with Sarah Alexander as my mentor. And Sarah is a leader within ALL and within COG, really in all things toxicity and outcomes. And she introduced me to Lindsay Jibb, who hopefully will be on here a little bit later, but she's a researcher, a nurse researcher at Sick Kids that does a lot of work on improving quality of life and psychosocial care for families and children. And while we were participating in the ALL committee meetings, there was a lot of discussion about the design of upcoming trials, and specifically a lot of discussion about designing a trial for certain standard risk patients in which we would consider a de-escalation or giving less therapy to decrease toxicity, but still try to have the same great outcomes. And every time the group talked about this, the conversation came up, which is great that it was coming up, is do we really know what patients and parents think is the worst part of therapy and what would be the best thing to try to de-escalate? And through these conversations, I ended up connecting with Kim, who obviously you guys all know, and then with Lisa Jacola as well, who is a neuropsychologist at St. Jude, and she does a lot of awesome work within COG on neurocognitive outcomes for children with cancer and undergoing therapy. Then Keobin was a pre-med student at the time at Sick Kids, now in med school, so can't be here tonight because she is taking an exam, I believe. Then Elham is another researcher that works with Lindsay at Sick Kids. And so together as a group, we decided instead of just wondering about what parents and patients think, let's ask them some questions so that we can design trials with that input in mind. And the ALL committee and the people really in charge of designing the trials were very supportive of this and really involved in a lot of this, which was just cool to see the openness to this. So we developed and disseminated the survey through Momcology to learn more about patient and caregiver priorities and preferences. The survey, as some may know, if you ended up doing it, was multiple choice and open-ended questions. It was available in English, Spanish, and French. And the questions were questions that we all came up with as a group and came up with as the ALL with the AL committee and some of the leaders on it. But then we had all eligible participants at least one eligible participant from each kind of type of participant pilot it and then incorporate the changes to make sure that it was understandable and make sure that we were asking appropriate questions in a sensitive way. And this is just a screenshot of what the site looked like with the survey on it. So what did we ask? We asked a lot of questions. We asked about the child or the patient. We asked about different things about their leukemia. We asked about the family. We asked about questions about the parents that were filling it out. We asked questions about the most difficult and disruptive parts of therapy. We asked parents to let us know if there was any questions that they felt like were unanswered research questions in ALL and to prioritize those questions. We asked about clinical trial decision making, and then we asked some questions about de-escalation of therapy. So as some of you may have seen along the way, we've used quite a few different approaches for recruitment, and this is a timeline of our first survey and the methods that we used. We're so thankful for Kim and all of her hard work that she's put into this, sending out emails and doing social media posts. We did a variety of those. We did a paid advertisement on Facebook to see if that would reach more people. And then we also did some targeted recruitment, just really trying to make sure we were going to get as generalizable as a population as we could. So trying to get more dads, trying to get more diverse race and ethnicity and socioeconomic demographics and the people we were asking these questions to. And so over 15 weeks, we ended up getting 546 survey responses, which is really just amazing for survey research. And we were so thankful to everyone that participated and everyone that helped us recruit. Of those 546 participants, 537 of those were caregivers or parents. You were eligible to take it if you were a patient. But not unexpectedly, since we were going through Momcology and not any sort of direct patient site, we only had 9 patient participants. Of the 537 caregivers or parents, 21 of those were bereaved parents, and the rest either had a child on therapy or after therapy. You can see from the map here, we got pretty great geographic distribution of responses. We got almost all the Canadian provinces, and we got all but 5 responses from all but 5 states. So we were excited about the geographic diversity that we got. You can see here, most of our respondents were mothers. We had some fathers. We had mostly white participants. We had a better distribution, I'd say, of highest caregiver education and household income, although could always still do better in those areas. We had a really good mix of current therapy status with a good amount of parents with children on therapy and a number of different years off of therapy. So anywhere from just completed therapy to teens to 20s of years off therapy. So a really good mix of that. Not unexpectedly, most were parents of children that had BALL and more younger children at diagnosis, so more 1 to 9-year-olds at diagnosis. The median age at diagnosis was 5.8, and the median age of the child when the parents took the survey was 11.1 years. So now we'll talk a little bit about the results, but I am only going to talk about results from parents of children with BALL that were 1 or older at diagnosis for now. And the reason I'm going to talk about this is just because this is our most common childhood cancer. The figure in the upper right is from the American Cancer Society, just showing that ALL is the most common childhood cancer. And it doesn't show within this chart, but within ALL, BALL is much more common than TALL. The figure at the bottom left is from work that Kim has done with a team at the University of Minnesota to look at how the momcology population compares to the general population of patients that get cancer. And that maroonish color is leukemia. It's all types of leukemia, so it includes AML, includes myelodysplastic syndrome, but really just shows that within momcology, there's a really large community of parents of children with leukemia. So we felt like starting with most common childhood cancer and recruiting from a community that we know has a lot of parents of children with leukemia made sense. And then the older than one is just because kids less than one that get ALL are treated really different than kids that are older than one. And it's a population that we really need to do this work in also, but didn't clump it into these results. And also, of course, part of choosing leukemia was that I specialize in leukemia, and so does multiple people in the group that I'm working with. But we will come back to TALL at some point. So first I'm going to talk through the questions about difficult and disruptive parts of therapy. So we asked what side effects of therapy were the most difficult for your child during the more intensive part of therapy or pre-maintenance, and parents could pick up to 5 responses, and then we then asked for each one they picked how difficult on a scale of 1 to 5, with 5 being the most difficult. And this is the responses we got. So the most frequently picked side effect during pre-maintenance that was difficult was nausea, vomiting, followed by decreased energy, neuropathy, constipation and bowel changes, and mood changes. And then the shades of blue are really just showing that if a parent picked one of these options or any of the options on the list, most of the time they didn't feel like it was just a bit difficult. For the most part, parents, if they picked it, felt like it was at least moderately difficult to very difficult, with the darker shades of blue being very difficult. I think a really important part of this research was not just those objective results, but it's what parents actually took the time to write out. So we have pages and pages of open-ended responses that we're just so thankful for and excited to make sure that we use this information. So I've just included a few for each question that are relevant to the most chosen answers, but that doesn't mean that all the answers that parents wrote out for us aren't important and aren't things that we're going to use. And for me, I feel like it's really the open-ended responses that make me understand some of the objective answers. So I'm just going to read a couple, but then I'll give everyone some time to read the other ones on here. So this is about the pre-maintenance and the most difficult side effects. One parent said, "Your child becomes so different than a normal child should be, wasting away, no appetite, no energy, tired, sick, laying around all day, etc." Another one that just kind of struck me was, "My daughter would scream herself to sleep most nights due to neuropathy." And I think, like, as a leukemia doctor, I see neuropathy all the time, and I know it can be painful, but hearing that a patient is screaming herself to sleep and a parent has to hear that is just, I think, really, it stood out to me to hear that. So I'll give everyone a brief amount of time to read through the others. We'll go on to the next question. So next we asked what side effects of therapy were the most difficult for your child during the maintenance phase of therapy. And again, parents could pick up to 5. And again, once a side effect was picked, they were asked how difficult. And the responses we got, and there is a caveat to this one, we accidentally only asked this question to parents of children currently in maintenance. So answers have to be thought of a bit differently, but still really important information to have. And we, in the future, do ask this to everyone. But for this one, it's just parents of kids currently getting maintenance. And the top picked side effect as being difficult was mood changes, followed by getting sick more often, constipation and bowel changes, behavioral changes, and then nausea and vomiting. And again, as shown by the shades of orange, when parents picked these, they truly felt like this was not just a small deal, that these were truly difficult. In the open-ended responses, again, I'll just read a couple and then give you guys a chance to read some. But one parent said, "Behaviorally, she had regression in her self-care skills. She is moody, angry, emotional, anxious, scared, occasionally aggressive, and difficult to calm." Another parent said, we were expecting him to gain back his energy and not be as nauseous during maintenance, but that was not the case. And I think these, especially like I think a lot of times as providers, we sell maintenance as this really great time. And I think oversell it a lot of times. And so reading some of the maintenance ones, I think were really impactful for me and things that I've already shared with people in my group that we really need to be careful how we talk about maintenance and how great we phrase maintenance as, because there is still a lot of difficult side effects during it. So I'll give everyone a chance to read the couple other ones on here. And I'll go on to the next one. So the next question we asked was, of the medications your child received, which ones caused the most difficulty and how difficult on a scale of 1 to 5? And this one is represented differently, but I'll explain some of the things in here. So by far and away, the most chosen medication was steroids, followed by asparaginase and then vincristine. And for all the questions, we looked at differences between answers of parents that had a child diagnosed from 1 to 9 years old versus those that had a child diagnosed from 10 to 19 years old. And obviously, we know this isn't a perfect way to look at standard risk treatment versus high risk treatment because younger kids also get high risk treatment. Plenty of kids go beyond the typical treatment and get relapse treatment. So we know that this isn't perfect, but it was the best we could do to kind of try to separate out standard risk versus high risk therapy and to just look at differences between how parents respond depending on how old the kid was when they were diagnosed. So the little stars are showing answers in which there was a significant more amount of parents in one of the groups that chose that answer. So for steroids, significantly more parents of children 1 to 9 years old chose steroids than parents of children diagnosed at 10 to 19 years old, but was still the most picked by both groups of parents. And then you can see for asparaginase and high dose methotrexate, it was picked by significantly more parents of children 10 to 19 at diagnosis, which also makes sense because those those kids we know get more asparaginase and get high dose methotrexate. So those answers I don't think were very surprising to us. Some of the comments that parents made for this question. One parent said dexamethasone pulses were extremely difficult. She had the typical steroid rage, moodiness, and increased appetite. But the most difficult side effect was the muscle pain and weakness she would experience. It would be crippling some days and keep her from being active. Another parent in the same quote shared thoughts on all three of the top picked ones. Prednisone caused roid rage, vincristine caused neuropathy, PEG made her horribly sick. And I like this one, steroids are the devil, because I think all of us can agree with that. So I'll give you guys a few seconds to read the other ones. All right. The next question we asked is, what components of therapy did you feel were the most difficult for you and your family, and how difficult? And I realize with these questions, we don't show how difficult parents ranked these, but for all of our questions, the mean difficulty rating was 3 or more. So for really all of the questions, we showed that these were difficult or disruptive for families. For this question, the two most picked answers were things that are unplanned. So the top one was unplanned or sick visits to the hospital or ER. And the second most picked was unplanned stays in the hospital overnight. And there was really no difference between parents of younger children and older children at diagnosis. For this one, the medications by IV or central line was picked by significantly more parents of young children at diagnosis, and then planned hospital stays by parents of older children at diagnosis, which those patients usually have more planned stays. So again, makes sense. When parents told us about some of these difficult components, one parent said, The effects of unplanned doctor's visits, ED visits, and overnight hospital stays were massive and wide-ranging. Not only a disruption in our routine, but significantly affected our finances, from the amount of time we needed to take off of work to appropriately care for our sick child. Another parent said, and I forgot to mention, the third most picked was procedures. And there were a lot of comments about lumbar punctures and procedures being difficult. One parent said lumbar puncture days were some of our worst throughout the whole 2+ years of treatment. And that was a sentiment shared by multiple parents that wrote comments for us. So I'll give you guys a few seconds to read the rest of these. And I think just as I'm reading these again, one of the things that a lot of these comments made me think about is I'm one of our fellowship directors, and I think our fellows take calls and they get really tired, and it all I think becomes like the same thing to them by the end of the year, telling parents to get up in the middle of the night and take their kid in. And so I think these are eventually, as we continue to disseminate this, I think that these are important quotes, and there's tons of these to share with our trainees that I think sometimes forget what a big deal it is to have families and patients doing this. The next question is, what aspect of your child's ALL are or were the most disruptive, and how disruptive? And for this question, the most commonly picked answer was a compromised immune system, followed by changes for siblings or family members, and then followed by changes in family finances. And for this one, significantly more parents of children diagnosed 1 to 9 years old picked the compromised immune system and changes for siblings or family members. And then significantly more parents of children diagnosed 10 to 19 years old picked missed school, which actually missed school was the second most picked by parents of that age group, which makes sense. The open-ended responses for this question. One parent said, my daughter's leukemia has made me miss my other daughter's last 2 birthdays, my son's most recent birthday, a lot of other moments with them and her compromised immune system and restrictions combined with a huge hit to our financial situation has limited a lot of the things a normal family like ours could do before cancer. I think this one stood out too, because I'm sure it is impossible, but one parent said it is impossible to choose only 3 items from the list above. We are 5 years out of treatment and our finances still haven't recovered. And I'll give people a few seconds to read the rest. And then we asked next, some children with ALL may have long-term side effects. Which of these effects are causing you the most concern, and how much concern? And when we asked this question, the most frequently picked potential late effect was neurocognitive deficits, followed by secondary cancers, then mental health changes, heart problems, and infertility. And within this question, parents with children diagnosed at 1 to 9 years old more frequently picked neurocognitive deficits and secondary cancers and teeth or dental problems. And then parents of children diagnosed at 10 to 19 years old, significantly more parents in that group picked weight changes. In the open-ended responses, one parent said, I have grieved the potential loss of fertility, and I try not to fret over the possibility of a secondary cancer. But in truth, both of these things make me feel extreme sadness and fear. Another parent said, treatment and cancer life never ends after diagnosis. My daughter faces the high potential for cancer again, which is utterly terrifying. And I think a lot of these comments commented on secondary cancers, and it was obviously picked frequently by parents. And I think this is one that stood out to me and other leukemia doctors when we talk about it, just because I think sometimes we breeze over this late effect when we say it because the risk is really low. But of course, when you're telling a parent that what we're giving your child could cause another cancer, that's not something that they're going to forget easily and not worry about. And I just think a lot of these quotes kind of reminded me that even though we say the chances are low, that doesn't mean it's not a scary thing for parents.
Hey, Kelly, quick
Mhm.
question just
Yeah,
came in the chat, just particularly about this slide. And someone was wondering, how common is it for secondary cancers to develop? And I wonder if in this question, did we just ask about secondary cancers or relapse?
we said secondary cancers, but we didn't give any like qualifiers for that. So it's definitely possible um that parents picked it because of relapse, but I think like the way it was phrased was more like a late effect. The risk of secondary cancer totally depends on what therapy and how much of it a patient got and changes if patients get relapse therapy. So I don't want to give any specific numbers, but I will say like it is one of the things that I try to reassure parents that even though we are mentioning it, the risk is very low, especially compared to some other types of cancer where patients receive higher doses of the chemos that can cause it. But I think when we presented this at an international conference, I think there was a lot of providers that were really surprised by these responses because the risk is so low. And I think it was a mom in the audience from oncology stood up and said, like, when you hear secondary cancer caused by chemo or by the chemo, you're not going to forget that, even if the chances are really low.
Totally agree with that. And I think, yes, talking about relapse too, and including it in that same breath is just, that's always there, right? It lives right under your skin for the rest of your life. So that's one of the things. And one of the things I think that we'll talk about at the end of the presentation too is what physicians found most surprising about this information. But I'll let you move on. I just wanted to address that.
Yeah, no, thank you. Because
Yep.
also I should say, like, I don't want the fact that a lot of parents are saying they're worrying about that to worry parents that aren't, because it
Right.
really, like, it is a very rare and small chance. So this shouldn't make anyone think they should be worrying about that more.
Yeah, good point.
Okay. Next, we'll talk about our questions related to clinical trial decision making and de-escalation of therapy. And first, I'm just going to give a little context of why we're asking these questions because, like I explained, the next trial, they're thinking about de-escalating therapy. And I already had some interest in this because my fellowship research project was about parental decision making regarding consent to randomization on the COG trial AALL0932, which before the most recent one closed was the most recent completed trial. And in that trial, one of the aims of it was to de-escalate or decrease therapy, so to give less than Christine and steroids in maintenance while maintaining excellent cure rates. And the great part was this trial worked, and we learned that we are able to give less than Christine and steroids for kids with certain types of BALL. But kind of anecdotally, at the institution I trained at, a lot of providers remembered parents having a really hard time making this decision of whether or not to have their child enroll and get randomized on this study. And so I did a study interviewing parents about this. And I think a lot of the responses in interviews I did made me feel like this was an important area to continue to look at. A couple quotes from what parents said when I did this study. One parent said, if something happened where the cancer returned and he got less medicine than was normal, that would have been very difficult for me to live with as a parent. Another parent said, there is so much that is already unknown. It is just adding more unknown. But if you can give them all of the side effects of the known, it would definitely aspire to do the unknown. I mean, if you explain the motivation is to decrease the long-term impact, that is a win. And I think one of the things that struck me also about this study is more than half the parents I interviewed said they were still thinking about this decision. And I interviewed parents that kept their kid on the study, and I interviewed parents that decided not to have their child randomized. And over half of them were still thinking about the decision from both kind of groups of that. And on average, I was interviewing these parents 8 years after they made the decision. So I think this just made me feel like we really need to learn ways to support parents in making these decisions and figure out how we can better do this and incorporate this into our trial design. And so that was a big part of me wanting to be involved in this and in us asking some of these questions. So this is a long question, but we asked, imagine your child was diagnosed with ALL today and you were offered the chance to have them participate in a clinical trial. The goal of the trial is to decrease the amount of chemotherapy your child would receive, which would potentially cause less short and long-term side effects. The researchers running the trial hope and believe the cure rates will be the same despite less therapy, but there is a chance that risk for relapse of ALL could be higher with this decreased therapy. Would you be willing to consider having your child participate in this trial? And of course, we recognize it's really hard to just say like, would you be willing to do this when you're not actually in that exact situation? But wanted to try to get a gauge of at least what parents thought, and it was really divided. Like about a third no, a third yes, a third maybe, with a little bit more parents answering maybe. There was open-ended responses for this question also, and we got a ton of good information and found a lot of themes within the answers. And so for, I think, a lot of the parents that answered yes, some of the reasons that they answered seemed to be, to help future patients. Some parents said like the desire for less side effects is really appealing, and so that's why they would do that. And then, of course, this isn't something a parent would totally know before their child is treated, but some parents that said they would do it felt like their child was overtreated, and this would be something important to try. Really across the board, a lot of the parents that said no, there were some like, I don't want my kid to be experimented on, but a lot of it was fear of relapse and just really wondering if this trial didn't work and the less therapy had higher chance of relapse, like could they live with that decision? I think the most helpful ones were the maybes, because there was a lot of good comments about what information would be helpful for parents to have, and why do researchers and oncologists think this trial is a reasonable thing to offer? What's the science behind it? And really just some good comments on communication from their providers about this. So I think that this question has already taught us a lot about things that we really need to make sure that we're being thoughtful about when we think about consents and support for future clinical trials. As part of that same question, we asked, if given the choice, what part of therapy would you most want researchers to eliminate, reduce, or replace? Because of course, this is kind of where this all started, and trying to think about where, if anywhere, would we de-escalate therapy based on what parents and patients want. And the responses are listed in an order of how frequently they were mentioned. So not unsurprisingly, steroids were mentioned the most, and all sorts of steroids were mentioned. I'd say probably specific comments to induction steroids were mentioned more frequently than maintenance or delayed intensification, but there was plenty of comments about maintenance and delayed intensification steroids as well. Lumbar punctures and intrathecal chemo, asparaginase, a lot of the different IV chemotherapies were listed, less long-term side effects, length of treatment, more targeted options. And then this box is the most frequently commented on ones, but these were all commented on at least a couple times. So I think it really just showed us, depending on how things went for families and patients, they may want us to consider adjusting different areas. But I think a lot of really good and thoughtful suggestions within this. Some of the quotes that parents gave when they were commenting on these, I just want to read a couple. One parent said, I wish there were treatments available that were less toxic. My son was a small child at diagnosis. The side effects we are still uncovering nearly 8 years later are heartbreaking. It's like we kept him alive to stay sick for his entire life. And then there was comments about really like vincristine, steroids, delayed intensification, some good comments about blinatumomab, some bad, some swear words, but I think a lot of a really thoughtful and good information for us in this question. We then asked what information would help you make the decision to eliminate, reduce, or replace. And parents, again, I think similar to the table I showed with the themes, I think a really common part of what parents said is like, just give us good information and have good communication about why this trial is reasonable. So again, I think really helpful things for us to think about when we're explaining trials and when we're designing them and designing the consents. Um, Not listed here, but also in some comments, parents talked about actual resources that would be helpful, like more lay language handouts, more online resources, more videos. And some of us are actually doing a study now interviewing parents about that specifically and what could be helpful for future clinical trial consents in terms of like would a video or an online module be helpful in making these decisions and giving information. And so that study that we're doing has kind of been led by some of these comments from parents. So then the last part of the survey is the research question prioritization. So we asked, are there any unanswered ALL research questions that come to mind while completing this survey? Obviously, there are many unanswered ALL research questions, so we're so thankful that parents that did this survey were willing to give us some, and we received 998 total questions that were submitted, which was really awesome. It was a lot of questions to organize, and the team at Sick Kids, led by Lindsay, really took this on and did all of this work, going through every question, kind of fielding through duplicates, looking at stuff that definitely has been answered, and putting these into categories that they then put into summary questions. So I think in total it was about 35 summary questions that kind of took all the questions that parents gave us and narrowed it down. You can see here that the most questions were about cancer control, survivorship, and outcome research. A lot of questions about treatment, but really there was questions about everything. So this was all part of the first survey, and then I will talk about a second survey that is currently circulating and asks parents to, out of these 35-ish questions, ask parents to pick their top 10 and then rank them from 1 to 10. Before I talk about the prelim results for that, I'm just gonna touch base on the second survey. It's even more hefty than our first one, and so we are so appreciative that people are taking the time to do this. There's questions about demographics in it. There is the question ranking, so the question prioritization, putting those top 10 in order. We ask about the de-escalation clinical trial participation again, but we also ask about an escalation trial where more therapy is given to gauge whether it's more about clinical trials or the actual fear of taking away fit therapy. We ask more about the impact of each treatment block and trying to think about, are there whole blocks we should be taking out and replacing with different medications like blinatumomab. We go deeper into delayed intensification and maintenance questions based on some of the responses from the first survey. We ask questions about immunotherapy and targeted agents because while we're all so excited that these are working and really probably changing how we cure leukemia, I think they don't come without burden. And so learning more about that and what we can do in the future to help with that. And then getting a little bit deeper into clinical trial participation, decision making, and really getting at possible distress that could be causing. And then because neurocognitive late effects was the top chosen one that parents were concerned about, we asked more questions about neurocognitive effects and school attendance. So some prelim results. So the survey has not closed yet. So these are not the final findings, but our prelim results from what we've gone through in the second survey for parents' top 10 research priorities were these. So number one, how can child ALL be prevented? And some of these are more addressable than others, but all really great questions that hopefully eventually in the future we can address. Number two is what causes ALL in children. Three was what are the best ways to minimize chances of relapse in childhood ALL? Four is what causes childhood ALL to relapse? Five is how can childhood ALL care how can child ALL care regimens be optimized to minimize the long-term side effects? Six was how can we better personalize therapy to each child with ALL to minimize childhood ALL treatment toxicities? Seven was what are the best ways to minimize chances of secondary cancer related to childhood ALL? Eight was what are the best ways to detect childhood ALL earlier? Nine, how can we optimize childhood ALL treatment such that we minimize side effects without decreasing cure rates? And 10, how do we design ALL treatment medications more specifically for children? So I think a lot of these do kind of cluster into similar themes, but I think are really great questions, and we're excited to share them with the oncology community and the people that really decide where we do research. So coming back to this, I'll come back to the second survey, but first I just wanted to touch on what we're doing with all this helpful information that's been shared. So a few of the things, so myself and others in our group have been asked to give numerous presentations at the Children's Oncology Group meetings where they're planning the next trials. Most of these have been within the COG ALL group and in thinking about planning the next standard risk, but also the next high risk trial. Some other committees have also started to get interested in the work and have asked about it and have had us present at their committee meetings. We gave an international oral presentation this year at an international childhood oncology conference, and we've submitted abstracts for other conferences to help disseminate it. We're gonna hopefully submit a bunch of manuscripts, hopefully one either tomorrow or the next day, with the questions about the most disruptive and difficult parts of therapy. We have one grant application in, but we're applying for more grants to further some of our questions about topics that came up in the first study so that we can continue to do future research in this. And then I would say just personal clinical experiences. And I brought up a couple examples, but reading through these answers like really has changed how I talk to parents sometimes and just really makes me think about a lot of the things that we and how we present it and what we say to patients and families. So going back to our second survey, touching on that, just want to make one plug for people to volunteer to take the second survey if you haven't and you're interested. So on this one, we've been recruiting over a longer period of time. We started in August of 2024, and we plan on closing it in the next week or two. One reason for the longer recruitment is we really wanted to reach some of the populations that we didn't as much the first time. And so specifically, like I said, looking for more diversity in race and ethnicity and socioeconomic status and more dads. To do this, we tried some new methods of recruitment this time, like text messaging, which we got advice from someone that does a lot of good research in increasing kind of the generalizability of results, recommended using texting. So we're trying that. We're thrilled. We're almost to 500 responses, which is great. But since the survey is quite long, each section doesn't have 500, but still really happy with how many participants we've gotten so far. But hoping to get a few more before we close it. So in terms of our next steps, I kind of mentioned these already, but we're trying as hard as we can to spread the word on what we're learning to the medical and research communities through conferences and journal publications. We want to brainstorm further opportunities for ongoing dissemination to all stakeholders like this, and spreading this to patients and parents in momcology and beyond. Grant applications for follow-up projects, we will look at the TALL data and our other parents that answered these questions that didn't specifically fit into BALL, because obviously that's important information too. We'll close the second survey, like I said, within the next couple weeks and then start that analysis and also figure out ways to disseminate that. And then hopefully eventually I would love to stick within leukemia stuff, but I do think that this is really important work to do in all different peds oncology diagnoses. So hopefully we'll start to and continue to collaborate with other people in disease specialties so that they do similar things. So not too late to participate. The ways that you can participate in the second survey, if anyone is interested, is eventually, I'm not sure if it's there already, but there will be a link in the chat. There's a QR code. There's a momcology, probably multiple momcology emails you got at some point that you could go back to, or the social media outreach. And then aside from the second survey participation, please reach out with questions or suggestions about any of this because we would love to hear all of it. And then with that, I think now we can go to the Q&A session. And just want to say thank you to the momcology community and Kim for letting us do this work and for participating. This is not our whole research team because we don't have Keoban and Elham, and we all have been together in person, but we never got a picture all together. So we had to, Lindsay and I meet on Zoom very frequently, so we had to stick with that. And we did finally meet at one of the COG meetings. And so, yeah.
Thank you so much, Kelly. I love these pictures. Looks like you're having a good time too, which is important.
We need one of the whole group eventually.
Yeah.
Yes, I think this was celebrating after some of the COG presentations.
Yeah, I love it. I love
I
it.
know I get nervous.
Time to relax. Yeah. This has been great. We are going to get to some Q&A here. We had a few questions come in, and we had some participants or some members that weren't able to come today submit some questions, knowing that this will be recorded and being able to be shareable in the future. But what I love, love, love about this and you being here and reporting back this results, I've been in the childhood cancer community for 15 years now. I've participated in a lot of research studies and surveys, and most often I never find out what happens with those contributions. Maybe because I like to find out about things, I'll look up, I'll Google it, look it up, and see that something was published. And I'll read it, and I'll probably be like, boy, I don't know if they interpreted that exactly right. I don't think they had an advocate involved looking at the results. So this is what's great, and I love that the community has the opportunity to learn from the results, to engage with you, to reduce the barriers between providers and patients with research. And really, I think there's an opportunity where the community can look at these gaps and help you and help us, right? To come up with interventions that are consumable and accessible to patient families based on these biggest gaps that we're seeing. So I think this is incredible. I'm so glad that you were here. I'm so glad that we were able to collaborate on this and bring just a great wealth of knowledge to the table, and to have pediatric cancer researchers who are at the forefront of designing new clinical trials for our children to leave things, to make things better than what we all had. And that's happening in leukemia. It's an exciting time in the treatment of leukemia. And to have every experience possible matter when we're looking at how to make it better for children with cancer and their families is incredible. So thank you for that. These are
Thank
big things. These are big steps forward. So
you.
very happy and very proud to be part of it.
And I probably didn't emphasize it enough, like how much the ALL committee and leadership is asking about these results and using them as they design the next trial. It's really exciting to see.
Yeah, and we're all part of it, which
Yeah.
is amazing. Yeah, and always have been, but in a new way, in an experiential way, not just what's in the labs or looking at outcomes and results. We're looking at that, but we're looking at the patient, family journey, and experience, and I think that's excellent. So we did have a few questions come up, and I'm not surprised about this one because it has me thinking too. It says earlier you mentioned a disconnect between how providers see or communicate about maintenance and what parents and kids might experience in terms of difficulties and challenges. And this person said that happens to be what their experience was. The expectations that were conveyed maybe go into maintenance, expecting it not to be as difficult as it was. What causes, do you think, this disconnect? And what can we do as parents to help with that communication?
I feel like what causes it is that we just see patients and families less during it. Like we're only seeing them once a month. And so I think we're fitting like what we used to do every week, which is like seeing them every week and asking how they're doing and seeing how things are going. We're not doing it as often. And so I think we sometimes kind of forget that that whole 4 weeks in between then, like it's not totally normal at home. And we do all have the patients that just kind of cruise through it and like really do feel like they feel okay. But even more so lately, like I've noticed once they come off therapy, parents are like, oh, they actually didn't feel as good as I thought they did. So I think part of it is we're seeing patients less, like there's less admissions during that time. And then I think people just don't know. Like when I was reading all the maintenance comments, particularly from our second survey, which like I said isn't closed yet, there's a lot of just maintenance questions in there. And I think we could write a whole article on the open-ended questions that parents wrote about maintenance about this, and for providers. Like, I think that's something I would definitely read in a journal that would be eye-opening to me. Like, even though it is like just oral chemo at home and some IV chemo, like this still isn't easy for families,
Right,
for patients.
right. Yeah, I mean, just a lot of the treatment of ALL, just by the nature of the disease and how it's treated, happens at home, right?
Yeah,
We carry a lot of the burden, and usually when we bring our child in for their monthly visit, it's right before they start another cycle, so
yeah,
they're actually feeling kind of good
right.
at that time. So no, I think that's great, and again, for me personally, managing school was just such a huge, huge part of my daily communication and a side effect of therapy, really. Making sure that my son wasn't taking standardized tests while he was on oral steroids because he just couldn't comprehend the questions at that point. It's just one thing. So, it's a lot. So I think that's good, and that's good advice. And I'm glad that this is also using, right, to inform oncologists and physicians that this is an issue. So I think that's fantastic. Another question that came in earlier in the session was from a mom, and she says it was hard going through treatment. Their child, and this is kind of you as a practicing oncologist can answer this. When their son went through treatment, was very young, and he doesn't really remember. Do I tell him about treatment? And what is that balance as they get older and have to care for themselves as young survivors of cancer?
Yeah, gosh, that's a good question that I think is probably family and patient dependent. But I think yes, talking about it is important because I think they're gonna know, and I think feeling like something was like hidden or they didn't have all the information could potentially be hard, and they are at risk for some late effects. Granted, luckily with a lot of the BALL treatment, not as um, much risk for some of the late effects as some other types of cancer. But I think in survivorship clinic, we have parents come through sometimes that are like, I don't want the kid in the room. Like, I just want to hear about it all myself. I don't want them to worry about this. And I think we do have a little bit of a hard time with that sometimes because they're going to grow up and they're going to be on their own. And I think it is important for them to know. I think sparing them some of the details, maybe about how terrible some of it was is okay. But I overall think it's probably important to share. Kim, you probably have thoughts on it with, I guess who's older, but like having gone through
Yeah.
it, like, yeah, I can't, I don't know.
Yeah, I think that every family functions a little bit differently, but I do think it's important, of course, that anybody kind of knows what's happened within their
Yeah,
body, right? And how to care for themselves and know that they may have some things that are different and they need different being able to take care of it. So I think that's definitely a work in progress in
yeah,
survivorship and a whole another level. That's probably a whole nother conversation, but those are delicate
yeah.
conversations for sure. Yeah, I know
No, it's
lots
a,
of families that have had children at how mine happens to remember, not everything, but certainly remembers a lot of it, being diagnosed at 8 through 12. But yeah,
yeah,
it's for that for those families, I do probably believe that it was more trauma probably for the parents and older siblings than it could have been for the young. But again, there's
yeah,
there's a lot that goes into court accessing and things, which is a whole, you know.
yeah. No,
Um,
it's a really good question that I haven't thought about that much. I have a 4-year-old and a 1-year-old, so like
mhm.
would be at ages that they probably wouldn't remember a ton. And yeah, I don't totally know without being in the situation like how I would approach a younger kid that then gets older and what to tell them and how to explain it.
Yeah, yeah. So we have just a few. I know we're running short on time here already, which means we've just had a really fruitful conversation and discussion. So here's a great question. It's about clinical trial decision making. It says they were very nervous when deciding whether to participate in a clinical trial. I can't remember, and I think this is in the survey, if it was asked whether people who did trials, if they regretted it or were very happy they did. And that's a great question.
Yeah. We definitely have some questions specifically in the second survey about that. And it's really like we're trying to look more into decisional regret, which all kind of goes into decisional distress, which is not something that there is a way to measure in parents specifically within pediatric oncology or pediatric ALL. But one of the grants that we are trying to get is to develop a tool to better measure like whether there is regret, whether there is distress related to this decision, so that then, unfortunately, this is how it all works, but to get funding or to find a way to support parents in that, you have to show that it's actually an issue for some parents. So we're trying to learn more and trying to develop tools to measure that. But that's all in the second survey, so we haven't looked deep into the results yet.
Yeah, there was a pre-submitted question that kind of was down that same path. Are there any resources or tools available to help what feels like impossible decisions to make during an already stressful time?
Yeah,
So, yeah.
there's not good tools yet. I don't feel like there's a lot of work being done in adult oncology on like decision aids, But of course, that's not going to just translate well to making decisions for your kids instead of making decisions for yourself. I think a lot of people are interested in it, and specifically, like Kim's been there for this next ALL trial. There's been a lot of talk about should we make more resources for this than we typically do. Like, should we make a video from the people that are leading the trial with them explaining the science behind it and why we think that these are safe things to do and how we came up with these decisions. So there's a lot of talk about improving the resources for parents. And then as part of that, I hope that we are also able to develop a tool to measure, are these things helping and how can we
Yeah.
develop them better and do better? But I think we're a ways away from a lot of that.
Yeah, it's an incredibly isolating experience, right? To have to go on a randomization on a clinical trial because you feel like you're the only one in the world making that decision. And in actuality, there's hundreds of families making that decision at the same time. And I always try to think about what are the little things that can take away the isolation. And I love that idea of there being a website, knowing that other people are seeing the same thing and it's being explained in a consistent way. I think that's a great idea. Yeah. Great. So we did have a pre-question about Blina, and there's also a question that came up on this live. So I'll kind of put them together. Can you tell us more about the future of blinatumomab and other immunotherapies and treatment? And then specifically, someone mentioned, are there studies open reviewing the effectiveness of more than 2 rounds of Blina? And I think that we're looking at lots of those questions. Yeah.
Yeah, all such good questions. There obviously is a lot of excitement over blinatumomab after the most recent trial, and I think probably a lot of people on here know, but in the most recent standard risk trial, it closed early because blinatumomab was improving outcomes so significantly for multiple different kind of groups of BALL patients. And so now across the country, most BALL patients will get blinatumomab, not every single one. But I think most places are incorporating it already based on those trial results for both standard risk and high risk. And that means the future of all BALL clinical trials will include blinatumomab as a backbone. So not necessarily as a study question of whether it works, but as a can we replace like delayed intensification with blinatumomab, and will that be as effective, or is 4 rounds of blinatumomab more effective than 2 rounds for more of our like higher risk patients that we still, we want outcomes to get closer to that 100 mark. So there are definitely going to be questions of how many rounds of blinatumomab are more effective, and questions of what can we replace with blinatumomab. I think things that our group is like really interested in is obviously like the medical questions, does this work, but also like how does that change burden of therapy? Like, is this better for families to do this? And then I think there's also some changes coming to how blinatumomab's administered eventually, and that it probably in the future, not for the next round of clinical trials, but in the future will probably be subcutaneous, so an injection instead of a continuous infusion, which I think a lot of people are like, oh, that's so much better. But we asked some questions in the second survey, just like, is that better? I know Rylaze is sometimes, or Erwinia is like the hardest part of therapy for kids when they have to get extra pokes. And so I think the assumption that that's going to be so much better for families is probably true for some, but not for others. So we're trying to learn more about what blinatumomab looks like for the future. But it will be a part of almost all ALL treatment, which is super exciting, but has definitely caused like a little bit of chaos just in terms of figuring out logistics and disparities and in administering it to everyone and making sure that there's equal access to all patients that need it.
Yeah. No, that's great. Thank you for sharing about
Yeah,
that. Like I said, it's just such an exciting time
mm-hmm.
in the treatment of
It
pediatric
is.
leukemia. Yeah. Um, Another question, have other studies like this been done in the past and have the results led to any significant changes in treatment?
That's a good question. I think as far as I know and as far as we've seen, like this is the biggest study like this with the most participants that has been done, definitely within ALL. And of course, there's a lot of studies like asking parents questions, but I don't think that I have seen anything that's been done on this scale in pediatrics. And so I don't actually know of big changes that have been made because of studies like this. That doesn't mean it hasn't happened some in other disease processes. So yeah, I think we will see. Do you know, like, Kim, do you have any idea of any others that like
I
within
do not. That's
oncology?
why
Yeah,
I'm very
yeah,
excited about this.
yeah.
And
I
we hope
think,
that it can filter to other disease groups as
yeah,
well. Yeah.
I think I didn't realize like as we were getting this many respondents, I think it was at PsyOp when we were at the international conference and someone was like, "Oh yeah, they a presenter that I hadn't even heard of brought up like this rumor that the biggest repository of parent responses was through Momcology, which we realized was our study that they were talking about." So I don't think there's been this much good information from parent and patient stakeholders. I can't totally speak to the adult literature, but as we've been looking at writing it up and stuff, I haven't found anything specifically
Yeah.
like this.
Yeah. It's great. Yeah. Someone just asked, is it okay to share the questionnaire on my own social media for friends in the community? Yes, absolutely. Yep.
Mhm.
Yep. Thank you.
Thank you.
Yes. Just a couple more here. And any questions that we happen not to get to, Kelly, if it's okay if we submit those to you and you can write responses and we'll get them back out to
Yeah, definitely.
the attendees of the webinar. I know we want to be mindful of everyone's time. Um, Here's a great question, and I think I know the answer. So, and it's a happy question. Do you see any kids that don't get any late or long-term side effects after treatment?
Uh, yes, I see a lot. I feel lucky sometimes that I do leukemia and lymphoma because I feel like I can truly like speak to my patients and parents about what I see in survivorship clinic. And for the most part, it really is that they're leading happy, healthy lives without long-term side effects. I think the psychosocial piece of it is honestly like the part that we need to be doing so much better. So our survivorship program just recently, we're we've been doing it for probably over a year. We're doing an early transition program so that parents and patients are coming to clinic within that first year so that we can really start working on the psychosocial pieces of going through this. And so I think that that will be good. But no, I really do see a lot of leukemia patients um, that are thriving, and I would say that's mostly what I see. One, should make sure I don't violate any HIPAA, but like going on to go to med school after going through lots of treatment and transplant and all of the things is something I've seen recently, which was really exciting. And I don't think that that's out of the realm of normal.
Yeah. No,
And
that's
that doesn't mean, I mean, there are plenty that do have some long-term side effects um, that are devastating to them. And so I don't want to minimize that at all. I think specifically in leukemia, avascular necrosis is like one of the hardest things for me to see because,
yeah.
yeah, it can really impact patients.
Oh my goodness, yes, yes. Real quick here, it's kind of the last one on the live Q&A. Does treatment for T-cell ALL in male young boys pose a higher risk for infertility in childbearing ages? And I'm guessing that just kind of depends again.
Say it again. We were,
Are boys treated for T-cell have a higher risk for infertility? Is it?
no, yeah, I mean, it depends on what they end up needing, but overall, the risk for infertility in both BALL and TLL, not counting relapse treatment, is quite low. And so for TALL, the risk calculation for infertility, as long as you just get like the standard treatment, still puts you into the low risk category, which doesn't mean impossible to cause some effects, and we never know what anyone's baseline fertility potential is. But one other nice part for leukemia is fertility if side effects are lower risk.
Yeah. Yeah, I think again, that kind of shows to our parental worry,
Hmm.
right? After going through this. And I think, and again, it ties back to that whole clinical trial decision-making thing. And I always say, we're not only making those decisions for our child, we're making them hopefully for that future adult. And we want them, to be happy with the decisions that we made for them. So it's very difficult and it's extra burden, I think, as parents when we're of course we're trying to save their lives first and foremost, but we're also wanting them to have the happiest, healthiest, productive lives possible with those years of life saved. So
Yeah.
it's just so important. So again, I think we can begin to wrap this up, but thank you for spending time with us. Thank
No,
you
thank you.
for answering these questions. I know that not everybody has access to someone like you that's able to just be able to provide answers like this. So being able to create that connection to someone, especially here together in this safe space, is really important. So thank you for
Thank you for letting me.
yeah, yeah. And then everyone, if you haven't already participated in that second survey, you do not need to have participated in the first survey to participate in the second. It is still open just for a short while longer. So please, please do. We want every experience to count and to matter on this. Because Kelly said it's probably one of the biggest things of parental information that's ever been collected. And I would assume that it's probably going to be looked at for many, many years ahead as we design, as clinical trials are being designed and new questions are being asked, that it's going to be referenced. So please have your voice counted if you can. Our next caregiver lounge, we're taking March off, will be in April, supporting families through change and loss. So I think that's another great one, and that fits into psychosocial care. And we will be bringing in some experts to talk about that as well. So with that, thank you, everyone. We wish you and your families a peaceful night, and thanks for being here with us. Take care.